Good evening, everyone, and thank you for joining us for this educational webinar, What Parents Need to Know, Pediatric Inflammatory Bowel Disease. First broadcast on Wednesday, March 23rd, 2016. My name is Kathleen Waite, and I am the Regional Education and Support Manager for the Crohn's and Colitis Foundation of America in our Northwest chapter based out of Seattle. I've been on staff for about 4.5 years and had Crohn's disease since I was 11 years old. Before we get started with our presentation, just wanted to tell you a little bit about the Crohn's disease and ulcerative colitis, and to improve the quality of life of the children and adults affected by these diseases. We are supporting the most promising research in the field at the country's leading facilities. We've invested more than $270 million into the best research and played a role in every major scientific breakthrough in IBD. The IBD Help Center has information resource specialists who can direct you in the right direction for information and connect you with resources and programs. One thing I want to point out is a brochure that is a guide for teachers. So it's something that you could get copies of for each of your child's teachers and give them to them at the beginning of the school year so that they know how to best support your child with Crohn's disease or ulcerative colitis. Through patient education, we can give patients and their loved ones the information they need to take an empowered role in their healthcare with their healthcare team. And at in-person events, you can connect with people in the Crohn's and colitis community. We also have online education programs like this one that feature national experts speaking in lay terms for patient audience and for their loved ones. You could participate live so that you can be in the interactive Q&A or watch the replay later. These are some of the programs that are archived on our site right now. The Power of Two connects those seeking support with volunteers who've gone through similar experiences with Crohn's or colitis. They speak twice on the phone or by email, and anyone can participate in this program, at least age 10, and that's for patients and caregivers, so parents, spouses. And you can apply online at ccfa.org and click Find a Support Group at the top. And one program that's really special that I want to make sure everybody hears about is Camp Oasis. It's our summer camp program for kids and teens who are entering grades 2 through 12 who have medically stable Crohn's disease or ulcerative colitis. And it's a special place because they can just be kids and try new things and have a really good time. We have pediatric gastroenterology medical professionals on site 24/7, and many of the cabin counselors also have Crohn's disease or ulcerative colitis. But the focus is not on the disease, it's on having fun, and the talk about the disease comes out naturally when the child is ready. We also have accommodations for campers who are on special diets, which varies by camp location. There is a registration fee, but there are scholarships available for all those who request them. Let me say that again because we're very proud of it. We don't want the registration fee to be a barrier for any child to attend Camp Oasis, so there are scholarships for all of those who request them. Some of the feedback from our campers, they said that it's been an amazing opportunity to meet people who understand what they're going through. The older kids can be role models for the younger campers, and everyone there understands your individual experiences and they inspire one another. Some of our kids will be faced with medical things throughout the year that aren't so scary because they know kids from camp who have been through those same situations. And then feedback from some of our parents. My son is 100% more mature, confident, joyful, and solid than before. Parents say that their child is refreshed and their spirit renewed and ready to face the world and get through the year. Their children are shown that they're not alone. And one parent said, "It has been a relief to see my child not always carrying the weight of his disease on his shoulders." We have 12 sites around the country, as you can see here, and they are throughout the summer. And down at the bottom here, you've got the URL where you can learn more about your particular Camp Oasis location and find your applications. Another program that I want to mention is Campus Connection. It has resources specific to college, including accommodations on campus, emotional and social issues and support for those, and the ability to connect with other college students. GI Buddy is an app that you can get for your iPhone or Android, and just track your disease symptoms and treatment, diet, lifestyle factors as you go. And so if you've got a kid who's on their smartphone already, they can be plugging in their disease symptoms and not have to tell you about it or worry about it, and then create a report to show how their disease is doing, to either share with parents and for themselves to take control there. CCFA Partners is a registry of patient-reported outcomes. We have more than 14,000 patients enrolled who every 6 months fill out a detailed survey about their disease history and treatment and lifestyles. And some really interesting things are coming out of this. We just had a research study that showed that fiber has a different effect on Crohn's disease patients versus ulcerative colitis patients, which came directly out of CCFA Partners and is something that we didn't know before. And we have it for kids and teens as well. Take Steps is a community celebration. We have walks around the country where you can come out with your family, your friends, your coworkers, your neighbors, everybody who can come out and rally around your child or teen with Crohn's and colitis. And it's an incredible day, really family friendly. Bring the dog, bring the stroller, and it combines high energy and fun with access to valuable information, education, and helps us fund research in our education programs. And then Team Challenge is another way that that you can get involved and meet some really cool people who are making a huge impact in the fight against Crohn's disease and ulcerative colitis while they train for endurance events like half marathons. So I wanted to go over quickly just a little bit about who is on the call because there is, since we can't see each other, we wanted to make it a little bit less anonymous. So as of a couple days ago, here are the registrants of who we've got on the call. A lot of people here for a child with Crohn's disease, a lot of newly diagnosed, and a lot of people who are new to CCFA and have not attended Camp Oasis before, so we hope that you will join us. And one thing that I want to point out also is that at camp, about a third of our campers have never been before. So I know that's one reason why some campers may be apprehensive is because they think they'll be the only new kid. That's really not the case. And even our teens, we have a lot of new teens every year. They haven't been coming for a long time. And we've got representation from around the country. So it's a lot of people, and welcome all. Thank you for being here. So I wanted to go over a couple of things of how GoToWebinar works. Down on the right-hand side of your control panel, toolbar there, there's a field where you can ask questions. So if you type those in, I will be keeping an eye on that while Dr. Lee is presenting. There's also the ability to raise your virtual hand. So if everybody would look at your control panel, and up at the top, kind of on the left side of the control panel, there's a little hand. Go ahead and click that. And let's see if you can raise your hands, because Dr. Lee may ask a question and see how many people have done this or that, and he'll want you to raise your virtual hand. So that's on your control panel. Let's see if some people are raising their hands now. Yep, we've got some hands going up. Great. Excellent. Thank you. Okay, I'm going to put your hands down now, but we'll remember how to do that, and we'll ask you to do it at some point during the presentation to make it a little bit more interactive. And we're also recording this program so that it'll be available for replay should you want to watch the replay after or share it with someone that you know. And now I would like to introduce our presenter. Dr. Dale Lee is a gastroenterologist at Seattle Children's Hospital in their Inflammatory Bowel Disease Center. He attended medical school at UT Southwestern Medical School in Dallas and University of Pennsylvania in epidemiology. He did his residency in pediatrics at UT Southwestern Medical School in Dallas and his fellowship in pediatric gastroenterology and a fellowship in pediatric nutrition at Children's Hospital of Philadelphia. He is a volunteer on our CCFA Northwest Chapter Medical Advisory Committee, and he also volunteers his time as a doctor at CCFA Camp Oasis here in Washington. Thank you, Dr. Lee.
Great. Thank you, Kathleen. It is my pleasure to join Kathleen, as well as all of the family members and potentially patients of family members here on this webinar. This is going to be a forum for us to explore some topics that I think are important to all families who have a child with inflammatory bowel disease, and it'd be a great opportunity, I think, to share this knowledge with loved ones as well too in the future going forward. As Kathleen mentioned, I am currently one of the GI doctors at the Inflammatory Bowel Disease Center at Seattle Children's Hospital. I've spent time in Texas as well as in Philadelphia for my medical career, so I know that we have some folks on this webinar from all around the United States as well too. So welcome to you all, and I look forward to this opportunity to speak with you all. The objectives of our time tonight with this webinar are to, number one, provide an overview of inflammatory bowel disease in the pediatric patient population. Next, to discuss how IBD impacts the pediatric patient, both physically, psychologically, and also socially. We're going to outline the various therapy options for inflammatory bowel disease and specifically describe how this is important and different potentially in children and teenagers. We're going to describe the role of nutrition in pediatric inflammatory bowel disease and also explore the question of, is nutritional therapy a viable option for inflammatory bowel disease? Next, we're going to discuss the importance of getting the pediatric patient involved in care early. And then finally, we're going to highlight several families of children with inflammatory bowel disease. We're going to begin with an overview of inflammatory bowel disease in children. So we'll start from the very basics. Inflammatory bowel disease encompasses a variety of presentations of inflammation in the GI tract. The two specific types of inflammatory bowel disease that are commonly described are Crohn's disease and ulcerative colitis. They are different because Crohn's disease can involve inflammation anywhere from the mouth all the way to the anus. Ulcerative colitis is unique because it involves only the colon and is isolated to only the colon. At present, this is the best way that we distinguish the two types of inflammatory bowel disease. In the future, we think that there will be more specific classification based upon a variety of different parameters. So I want to give you all a little bit of a sense of how many children have IBD around the United States and how common of a condition this is. So an estimated 1.4 million people, children and adults included, in the United States have inflammatory bowel disease. This breaks down to nearly 440 per 100,000 people that carry diagnosis of inflammatory bowel disease in the U.S. Interestingly, about 1/4 of all IBD is diagnosed in the pediatric age population, and the incidence in children is about 7 to 10 children out of every 100,000 children develop IBD every year. The prevalence of inflammatory bowel disease is approximately 50,000 children in the United States. Here at Seattle Children's Hospital, we follow about 800 children who have inflammatory bowel disease. The frequency of diagnosis of inflammatory bowel disease has gradually increased over the past decade, over this time span. And an important consideration is the difference between IBD in adults and children, and we'll go over this more in detail as we continue the webinar. So I'd like to go over some of the symptoms of inflammatory bowel disease. Many parents and children are going to be very familiar with these, but there can be quite a variance in the type of symptoms that your child or you as an individual with IBD present with. So some common symptoms are frequent or urgent bowel movements. There's diarrhea that can occur as well. Though frequent stooling is the most common presentation with IBD, some people with Crohn's disease in particular can present with constipation. So bleeding in the stool can occur, and abdominal cramping is also a presentation that is a frequent symptom. So I think the distinction between in adults and children is important to consider. So in general, the presentation of IBD in children is more severe than in adults. So if your child is diagnosed with ulcerative colitis, they are more likely to have been diagnosed with a pancolitis, which means entirety of the colon. It's about 80% of children with UC. Children with Crohn's disease have a 20% risk of surgery or developing complications of their disease within 3 years of diagnosis. Children are more likely to have upper GI tract involvement, so involving their esophagus, stomach, or proximal small bowel than adults. In thinking about the frequency of Crohn's relative to ulcerative colitis, in adolescents there is a greater ratio of Crohn's to ulcerative colitis than in adults. In children, it's important to consider the effects of inflammatory bowel disease on growth and puberty, and we will be going into this a little bit further. And also, there are unique psychological and social concerns and aware of in our pediatric population. So I imagine you're a GI doctor and ask, so why exactly does my child have inflammatory bowel disease? Was it anything in particular that I did or that occurred for my child? So when we talk to our families about what causes inflammatory bowel disease, it begins with a genetic predisposition. Our environmental triggers, for example, antibiotic exposures, certain food exposures. There is, of course, the role of the intestinal microbiome. And all of this comes together to stimulate an abnormal immune response. Inflammatory bowel disease occurs when that inflammatory immune response is unchecked and continues to be a cycle. Talking about a little bit of the specifics of the genetic predisposition of IBD. So children of an adult with IBD have an increased risk of having IBD. It's 2 to 10 times greater than that risk of a general child in the population. There are 15 to 20% of patients who have close relatives to IBD, and if you're a child, you're more likely to have a close relative with IBD. Identical twin studies are always quite interesting because these studies teach us a little bit about the role of genetics, because identical twins have the same genes. So identical twins with Crohn's disease have a 50% risk of their other twin having Crohn's disease. If you're an identical twin with ulcerative colitis, there's only a 15% risk of your identical twin having UC. So as you can see here, it appears that Crohn's disease may have a slightly higher genetic link or risk. So there's a lot in the media about the intestinal microbiome and the bacteria that live in your GI tract. So there are trillions of bacteria in the intestines, and these are an important part of who we are and how we function. So these bacteria can change dependent upon our personal genes. The food we eat can impact the bacteria, and the antibiotics that our children receive also can impact the bacteria in our GI tracts. So it's very clearly established that bacteria are different in patients with inflammatory bowel disease, and it's known that the bacteria in the GI tract are a main activator of the immune system. I want to draw your all's attention to this schematic at the bottom of this slide here. So on the left side, you see a picture of a nice brush border of the intestine. The pink is the epithelial layer, or sort of the protective layer of the intestines, which is covered by mucus. We see in this first slide on the left side here, irritation being caused by bacteria. On the right side, you see bacteria, which are sort of these triangular and rhomboid-shaped shapes on this slide here. We see that bacteria are penetrating this protective layer of the intestine, and what's happening is they're stimulating an immune response. In the setting of inflammatory bowel disease, that immune response goes unchecked and becomes a cycle. So IBD has a unique impact on children, and part of the reason it's unique on children is children, unlike adults, are growing individually. So have children who presented with growth deceleration for inflammatory bowel disease, but this is a very common presentation. So for certain children with IBD, growth may actually be the first symptom of this condition. We know that with inflammatory bowel disease, there's a decrease in the rate of growth and a decrease in height percentiles. Many individuals with inflammatory bowel disease have a compromise in their adult height. With Crohn's disease, this occurs in 32 to 88%. This is a widespread, but this is what studies show. With ulcerative colitis, again, we see that there is a frequent decrease or compromise in adult height, but this is less so than with Crohn's disease. The causes of compromise in height can include ongoing inflammation, steroid use, as well as poor nutrition. If you have a child with inflammatory bowel disease, it's important to follow growth trajectory because growth is actually a very important and good marker of disease activity. I've had patients who feel totally well, but have a very mild elevation in their inflammatory markers. And for some of these children, this signifies ongoing inflammation, and their growth really reflects that this ongoing inflammation is causing problems with growth. So I would continue to discuss height and weight with your pediatric GI doctor as you guys go to your regular clinic follow-up visits. So bone health is an important consideration in children and teens. So really, when you are a young child and a teenager, you are laying down bone into your bone bank. By the time you are in your 20s and 30s and thereafter, you are only taking bone out of your bone bank. So it's very important that for our children that we help them lay down the appropriate amount of bone. We know that children with inflammatory bowel disease have decreased bone mineral density, and this may be related to poor calcium intake or absorption or vitamin D deficiency. We know that physical activity or inactivity can be related to lower bone mineral density, and definitely we know that steroid use and ongoing inflammation are both detrimental to bone mineral density and bone health. So it is important when we think about bone mineral density in children. Number one, ensure that disease inflammation is under control. Ensure that we are getting our adequate calcium as well as vitamin D, and also encouraging weight-bearing exercises. So puberty is a very important time period in adolescence. So there are important sort of medical, psychological, and emotional facets to going through puberty. We know that active inflammatory bowel disease can have a detrimental effect on puberty and cause a delay in puberty. So this is caused oftentimes by poor nutrition, ongoing inflammation in the body, and it may or may not be later in life in terms of growth and pubertal consequences of puberty. So for example, if you have ongoing inflammation and you have a delay in the age at which you achieve puberty, you may have a compromise in your peak height velocity and your ability to achieve optimal or genetically predisposed height. So there is a delay in puberty or peak height velocity in about 25% of children with Crohn's disease. The delay is usually 6 to 12 months. And the consequences to this are, of course, growth, but also potentially psychological impacts as well, too, as children are compare themselves to their peers in terms of their development and their height and other pubertal considerations. So I want to briefly touch on the psychological and social effects of having inflammatory bowel disease. Importantly, it's important that children understand that inflammatory bowel disease is a chronic illness. Unlike an infectious illness that resolves after treatment or gets better on its own, inflammatory bowel disease is lifelong, and there are consequences to that. Children with IBD sometimes have difficulty coping with procedures, clinic visits, and hospitalization. Oftentimes, adhering to complicated medical and dietary regimens can be challenging for children. Quality of life and social interactions can be impacted by symptoms and the therapies that are instituted. And of course, it's quite important to have appropriate support systems available at home and at school. And we'll touch on these a little bit further in this presentation. So studies have demonstrated that children and teens with chronic disease are definitely at greater risk of psychological stressors. They may have low self-esteem, they may have compromised social functioning, and they may become depressed as well too. So as you and your child with inflammatory bowel disease meet with your physician and your inflammatory bowel disease team, it's important to think about the psychological and social functioning of your child, and also to be thoughtful about quality of life. We as physicians sometimes focus on inflammation, but in certain situations, inflammation is under good control and the child is not functioning well. If that's the case, it's important to be thoughtfully supportive and potentially bring in social workers or psychologists or other resources to make sure that the child is well supported. I'm going to shift gears a little bit, and we're going to talk about therapies for inflammatory bowel disease in children. The goals of therapy are, number one, treating inflammation. Number two, induce remission of symptoms. And there is a distinction, of course, between inflammation and symptoms, because you can have symptoms even after the inflammation has gone away. A third goal is to prevent complications and surgeries. A fourth goal, restore and maintain normal growth and development, which is important in childhood. Fifth, provide safe treatment that's also cost-effective. And finally, we want to make sure that quality of life is appropriately optimized for our children. So there are some difficulties with the treatment of inflammatory bowel disease in children. So first of all, there is limited data in pediatric IBD therapy, and I say this with a grain of salt. There are very good studies in children, but there are many more studies in adults. So oftentimes the treatment approaches specifically with medication for children are extrapolated from adult studies. And from my perspective, it's always important to remind the adult GI doctors that children are not just small adults. They have many different needs, and they are growing and developing, which is very different than an adult. With children, there is concern of drug toxicity or drug adverse effects. With immunosuppressive therapy, there is a risk of infection. There is an increased risk of certain sorts of cancer. And an important consideration is the duration of therapy that a child needs to be on. If you are started on therapy as a child, it may be the case that you have a longer exposure to medications or other therapies than an adult who is diagnosed later on in life. It's important for us as we think about studies for IBD to be thoughtful about clinical outcomes that are pediatric specific, for example, growth and puberty. I'm going to go over 3 different treatment approaches here. I've distilled them down to medications, surgery, as well as diet. I imagine many of you who are on this call today have children who are on medications for inflammatory bowel disease. I imagine some have had surgery, and I imagine some of you all have been thoughtful about trying to institute dietary changes as well too. So I'll touch on all of these. I'm going to go over the medications first. For Crohn's disease, the potential medication options are antibiotics, immunomodulators, steroids, and biologics. For ulcerative colitis, the types of medications are quite similar, but also includes 5 ASA medications, such as the mesalamines. An important consideration that your GI doctor may have touched on with you all is the idea of inducing remission versus maintaining remission. Induction is the time period when you have active inflammation and you're getting that active inflammation under control. Maintaining remission is keeping a good thing in a good place. So the potential therapies that can be used for induction of remission include prednisone, cyclosporin or tacrolimus, or exclusive enteral nutrition, which is a dietary therapy I'll touch on later. Biological therapies such as infliximab or adalimumab are also used for induction, but can also be used for maintenance. And the 5 ASAs, such as the mesalamines, can be used for induction and maintenance. Some medications that are used only for maintenance are 6-MP or azathioprine and methotrexate. The reason 6-MP, azathioprine, and methotrexate are maintenance medications and not induction is they take approximately 2 to 3 months to work. An induction therapy needs to get the inflammation under control much more quickly. Steroids, you may have had a child who has been exposed to steroids. The specific examples are prednisone, budesonide, or hydrocortisone enemas. Steroids are effective at inducing remission of disease. They have potential side effects. If you've had a child on steroids, you may know that they have had weight gain, some mood disturbances. Over a long-term, exposure to steroids can be associated with decreased muscle mass as well as bone mineral density compromise as well too. Being on steroid for a long period of time is not a good thing. So the take-home point at the bottom of your slide is steroids should be used for induction of remission only. It should not be a long-term medication. If it is the case that your child needs to be on steroids multiple times per year, it may make sense to reevaluate the treatment plan and speak further with your doctor about changing the medicinal or overall treatment approach. Immunomodulators are a common medication used for maintenance of remission for children. So again, they take some time to work, so they're not good at inducing remission, but they can keep the inflammation for IBD under good control. Examples for this include 6-MP, azathioprine, as well as methotrexate. These are good at minimizing the amount of steroids that your child needs to be exposed to. And again, they're effective at maintaining remission and can be used in combination with or without biologics, which is what I'll touch on next. Immunomodulators do suppress the immune system, and specific risks include, with methotrexate, the possibility of fetal abnormalities. So if I have a child who is of childbearing age and is female, I think long and hard about if methotrexate is the appropriate medication for them to be on. With being on an immunomodulator, there needs to be monitoring of white blood cell counts as well as liver function enzymes. There's a slight increased risk of lymphoma with immunomodulators as well too, and we will talk about risk in just a moment. The biological medications that I'm going to talk about are adalimumab and infliximab. These are very effective at inducing remission of inflammation and also maintaining remission of inflammation. It's been demonstrated that these medications are very good at supporting growth. If you have perianal fistulization or if you have other fistulas in the small bowel, biologics are very good medications. There is a risk of infection with being on a biologic because these are immunosuppressive medications. Adalimumab is given by injection, while as infliximab is given by IV infusion. If you have any injections or infusions, there's always the risk of pain or swelling at the site of the needle going in. With the biologics, there's a slight increased risk of psoriasis, which is an inflammatory condition of the skin. And again, like with the immunomodulators, there's a slight increased risk of lymphoma if you're on a biological because these are immunosuppressive medications. So when I'm in GI clinic and I'm talking to a family about the possibility of starting an immunosuppressive medication, an important discussion and consideration we have is, so what are the risks of starting an immunosuppressive medication? Our immune systems are designed to fight off infections and also to surveil for abnormal cells. So I want to talk a little bit about the increased risk of lymphoma and how this is viewed in the context of other risks. So adult studies have demonstrated that adults have a baseline risk of lymphoma of 2 in 10,000 per year. Studies have demonstrated that the risk of lymphoma while being on either 6-mercaptopurine or infliximab rises to about 4 to 6 in 10,000 per year. To put this in perspective, the probability of dying from an automobile accident is about 38 in 10,000 per year, and the probability of a major surgery due to a complication from Crohn's disease within 5 years is about 1,780 in 10,000. The take-home points from my perspective are there clearly is an increased risk of lymphoma with being on certain immunosuppressive medications, but the increase in risk is very small compared to the potential benefit. It's important that when I as a physician speak to my patients about starting a new medication that we balance the risk and the benefits, and it's important that the benefit does outweigh the risk. An important consideration in the young adolescent male population or even just young male population is evaluating the risk of combination therapy. There is a certain kind of a lymphoma called hepatosplenic T-cell lymphoma, and this seems to be more likely to occur in young adolescent males who are exposed to 6-MP or azathioprine, so we are thoughtful about starting these medications in this patient population. So as you think about the right therapies for your child, there are some important questions to consider discussing with your healthcare team. First of all, what are the risks and benefits of the current treatment plan? Second, what is the risk of not treating the disease? If the risk of not treating disease far outweighs the risk of using a medication, this is an important balance to strike. What are the side effects of the treatments that are started and how can we manage these? Fourth, what is the plan if the current treatment regimen is not working? There always needs to be thoughtful consideration of next step and next plans if a particular therapeutic regimen is not working. And finally, an important question is to ask what vaccines are allowed when I'm on or when my child is on certain medications. For example, if a child is on an immunosuppressive medication, live vaccines are generally not appropriate, so consideration has to be given to the timing of live vaccines for these children. I want to briefly touch on directions for future therapies. At present, there are quite a few studies ongoing that are comparing studies or comparing therapies head-to-head to define really what are the most effective treatment strategies that have the smallest risk profile. We've learned that it's important for us to stratify risk of disease progression or risk of ongoing inflammation. For example, children who have deep ulcers seen on endoscopy are almost 3 times more likely to have active disease at the end of 1 year than those without deep ulcerations. This might help us think about being more aggressive with therapy up front if there are deep ulcers present. There's a very large push and interest right now in the role of diet on IBD therapy. Diet is well known to manipulate or alter the GI tract microbiome, and many studies are undergoing to better understand how we can use diet as therapy. There are numerous new medications in the pipeline. Vedolizumab is a medication some of you may have heard about. This is already on the market and being used in pediatrics and has been demonstrated to be beneficial, specifically in certain patients who have lost efficacy to anti-TNF alpha biological medications such as infliximab or adalimumab. When we think about the future of IBD treatment, really in the future we think that genetics, understanding genetics is going to be important. Certain blood markers of disease status and the characterization of the intestinal microbiome are going to help us understand what type of IBD you have and sort of what the prognosis of disease progression is going to be, and also help us understand what the most effective therapies are going to be, and really allow us to target therapy that has the greatest benefit and the least amount of risk for children. The CCFA has been instrumental in helping support research for both genetics and the microbiome, and this is an area where things are really going to open up, I think, within the next 5 to 10 years. And we, as your GI provider teams, will, of course, be talking to you all about the latest developments. I want to talk next about surgery as a potential option for therapy for inflammatory bowel disease. The goals of surgery are really to prevent complications of disease, alleviate symptoms, achieve good quality of life, and to preserve the most amount of bowel as possible. Sometimes surgery on its own can be an effective therapy. Other times, surgery plus medications are the right approach. So the indications for surgery are as follows. A child with really medically unresponsive disease or who is dependent upon steroids may be a good candidate for a surgical intervention. If a child is having really significant side effects from medications, surgery may be an option. If your child has developed an obstruction or an abscess, which is an infectious focus in the abdomen or around the perianal region, surgery is an appropriate discussion to have. Children with severe perianal disease oftentimes require surgery or interventions around the anus, and sometimes even require ileostomies or ileal diversions to divert the fecal stream away from the rectum. Children that have severe growth failure or have very poor quality of life sometimes respond well to surgery and can have significant improvements over time. I'm going to briefly touch on some of the common surgeries for both Crohn's disease and ulcerative colitis. This is by no means a comprehensive list, but I would like to touch on some of the more common surgeries. For Crohn's, a stricturoplasty is a surgery in which a narrowed or scarred down segment of intestine is opened up to allow for more easy passage of stool and food contents through the intestines. Small intestinal segment resections are a surgery that can occur for Crohn's disease in the setting of significantly active disease, or if there is a stricture that is unamenable to stricturoplasty. In Crohn's, partial or complete removal of the colon is occasionally an option. Proctocolectomy is a surgery in which there's removal of the colon as well as the rectum. The rectum is the most distal or downstream part of the colon and is important specifically as we consider surgery for ulcerative colitis. An important distinction between Crohn's and ulcerative colitis. Ulcerative colitis is isolated only to the colon, so removing the colon altogether can be effective curative therapy for ulcerative colitis. For Crohn's disease, taking out the colon is not curative because inflammation can recur in other areas of the GI tract. The surgeries to consider for ulcerative colitis are proctocolectomy, and this is again removal of the colon as well as the rectum. With this, the small intestine is able to be used to create a pouch or a reservoir, which is the function of the colon, and the reservoir is able to be attached to the anus, and so this is a surgery that can be done to recreate the reservoir effect of the colon and to help children be continent. There are risks with surgery, as with any sort of a medical intervention. With Crohn's, there's no guarantee that resection of a segment of intestine is going to result in complete cure, so there can be recurrence of symptoms. children with Crohn's disease at times need to get an ileostomy. This is a procedure where the small the ileum is brought to the skin level and stool contents are emptied into a bag attached to the abdominal wall. And of course, there are potential psychological implications of having an ileostomy in place. So it's important that we as the medical team are actively involved in supporting the child. With ulcerative colitis, the surgery where you remove the colon and the rectum and then create a pouch from the small intestine, this can be a very good surgery, but the potential side effects or risks from this are the possibility of ongoing inflammation in the constructed pouch. Pouch failure can occur, which is when the surgery sites break down and there's leakage of stool contents. And again, with ulcerative colitis, children may end up with an ileostomy, and there are impacts to this. For both ulcerative colitis and Crohn's disease, anytime you have surgery, there's a risk of infection and bleeding, as well as sort of surgical site complications. We've talked about sort of a broad array of medicines and surgery, and both the benefits and the side effects that I've discussed apply to both adults and children. I'd like to talk about a few special considerations in children. Importantly for myself as a pediatric GI doctor, I want to know how my therapies and how the disease is affecting the children that I treat. Unfortunately, there are not as many studies looking at pediatric or child-specific considerations. We have learned from studies that children tolerate procedures and surgery very well and are quite resilient. Studies looking at quality of life in children suggest that children who have inflammatory bowel disease have better functional outcomes than adults with inflammatory bowel disease. Again, I like to think of children as particularly resilient, and also I am always blown away and impressed by the amount of support that the families and friends of children with inflammatory bowel disease are able to support. Interestingly, when parents are queried about their child's quality of life, there is ongoing concern for both physical and psychological limitations, so this is important for us to consider as we treat our children with inflammatory bowel disease. So as Kathleen mentioned, one of my areas of interest and expertise is nutrition in the setting of inflammatory bowel disease. So I'd like to talk a little bit about the role of nutrition in IBD. We'll briefly talk about therapy, nutrition as therapy as well too. So diet is defined as the food that you eat on a daily basis. The nutrients in your diet include fat, protein, carbohydrates, vitamins, and minerals. It's important to be thoughtful about food choices, as many of you all have experienced and learned, I'm sure. Certain foods can worsen symptoms for your child, and certain foods actually can cause children to have worse flare activity. So IBD patients are at risk of becoming poorly nourished, and this can occur because there's poor appetite related to nausea or pain. If you have chronic disease over a long period of time, you may have increased caloric needs, so it may be the case that just a regular diet's not enough and significant supplementation is needed. And children with IBD have poor absorption potentially. Inflamed GI mucosa does not do a good job of digestion or absorbing nutrients. So some principles of good nutrition. First of all, good nutrition is important for healing of inflamed, the inflamed GI tract. It's important for functioning of the immune system, and nutrition is really the substrate for energy. Good nutrition can be important for preventing or minimizing GI symptoms, and having a good nutritional backdrop may be important for making your medications be more effective as well. And of course, appropriate nutrition is just critical for preventing growth delay and being able and supporting appropriate weight gain. So many of you all may have thought or discussed with your GI doctors, is dietary therapy appropriate for my child's inflammatory bowel disease? I'll talk a little bit about what the data shows, and I'll talk a little bit about what the sort of newest studies are showing as well too. So exclusive enteral nutrition is a therapy based upon drinking formula and not eating table foods. This is a common therapy utilized in both Europe and in Canada for Crohn's disease. So this therapy has been demonstrated to be effective at inducing remission of active Crohn's disease in about 70 to 80% of children with Crohn's. One of the difficulties with exclusive enteral nutrition is that it's difficult to maintain long-term, and there are social impacts on a child who is not able to eat food and is consuming only formula. One of the benefits of exclusive enteral nutrition is that it can be used to minimize steroid exposure. If you are thinking that this might be an option for your child, it is very important to discuss further with your doctor about using this therapy, monitoring caloric needs, and also monitoring the efficacy of this therapy for your child. So you may have Googled diet and inflammatory bowel disease, and you will probably see about 1 million different things that different people have to say. As of right now, it's hard for us to say definitively that a specific diet has been proven to treat inflammatory bowel disease. There are many options and many things promoted on the internet, but few of them are really thorough, rigorous studies, really examining very thoughtfully if diet is beneficial for inflammatory bowel disease or not. One thing is many of these exclusion diets are difficult to follow, they're quite complicated, and some of them may restrict children so severely that they don't get enough calories in or become deficient in nutrients. Some of the diets may actually worsen symptoms. I'll say many of you all may have heard about the specific carbohydrate diet. This is a diet we do support at Seattle Children's Hospital. It may be supported by your doctor as well too. It's a highly restrictive diet, and studies have demonstrated that it appears to be beneficial for some children with inflammatory bowel disease. But again, in my opinion, extremely important that you speak with your doctor or a registered dietitian about considering a dietary therapy for inflammatory bowel disease. I tell my patients sometimes dietary therapy on its own is quite effective, but for the majority of patients, using dietary principles or dietary therapy and conventional medical therapy is the most effective way to get the children feeling well. Some general nutritional information. So with inflammatory bowel disease, we know that the food in your GI tract has an impact on your symptoms and inflammation. Some general principles for good nutrition. For foods, whole grains are beneficial, and I'm talking about children who are doing well and not with an active flare at present. High quality proteins are good and important for children. Deeply colored fruits and vegetables have a lot of vitamins and minerals in them. Fat dairy can be important, and appropriate healthy fats. So again, a good balance of whole grain carbohydrates, healthy proteins, and healthy fats. There's a list of supplements here on this table on the right, and I'll say for the vast majority of my patients, they take a multivitamin and they may be on vitamin D. Vitamin B12, calcium, and folic acid are supplements that you may be determined to be needing by your doctor or dietitian, but again, say daily multivitamin and vitamin D are the most common supplements that my patients are on. So an important consideration is thinking about what kind of food to eat during a flare. Many children and many families will note that their children gravitate towards specific things. One recommendation that we have during a flare is to limit insoluble fiber intake. Insoluble versus soluble fiber are quite different. Insoluble fiber adds bulk to stool and makes it such that the stool is able to transit more quickly through the intestines. Examples of this include fruit peels, many vegetables, and wheat bran. Soluble fiber, on the other hand, is different. This dissolves in water, it forms a gel, and it actually slows digestion. Oatmeal, for example, is an example of one soluble fiber. When a child is in a flare, it's important to think about decreasing the amount of concentrated sweets that they're consuming. I find that when children eat smaller, more frequent meals, their flare activity is much less exacerbated. If you have a child who in particular has a stricture, it's very important to avoid nuts, seeds, and kernels of things like popcorn. And the reason behind this is if a stricture is present, this is a narrowing of the intestines. If you have a narrowing in the intestines, consuming something that can block it can result in significant problems for your child. When I have patients in a flare, I do recommend that they consider a lactose-free diet and a lower fat diet to prevent malabsorption of fats potentially. When a child is in need of nutritional supplementation, there are a variety of different options. They may need supplementation due to weight loss, surgery, recovery from surgery, or just ongoing severe inflammation. So we do like to recommend liquid nutritional supplementation. We have some examples here: Pediassure, Ensure, and Boost. Enteral nutrition, so liquid nutrition in the GI tract, can be delivered via a nasogastric tube or by placement of a gastrostomy tube, which is a special tube that's placed either by the GI doctor or surgery in a tube going through the wall of the stomach, wall of the abdomen into the stomach. There are also IV nutritional options if a child really is not tolerating nutrition in their GI tract. I'm going to shift gears right now and talk a little bit about the planning for transition of care if you have an older child with inflammatory bowel disease. Transition is clearly a long process. It's really setting up our adolescent child for success as they transition into an adult healthcare system. The transfer of care is actually a single act where they go over and their bulk of their medical care is transferred to a different adult practitioner. There are a variety of reasons for a patient with IBD to transition to an adult provider. Age, of course, is critical. Socially, it may be more appropriate for a patient with IBD to see an adult provider due to privacy-related concerns as well as the desire for more autonomy. When a child is nearing time for transition, they may be working and not in school, and it may be more appropriate in this environment for them to be seeing an adult provider. There are different resources and insurance considerations as a child gets older and gets ready to transition as well too. As a pediatric GI doctor, I am not expert in taking care of folks that are married or have children, so again, this is more so the domain of an adult GI doctor. Adult GI doctors are well-versed and can guide a GI patient or an inflammatory bowel disease patient in screenings for certain types of comorbidities as well as for colon cancer. They are also going to be more well-versed at guiding the patient with IBD through the role of smoking, alcohol, and drugs on their disease course. Really, transition to an adult provider should be in phases. Really, a pediatric provider is most appropriate for the majority of patients, and I imagine for the folks on this call. But as a child enters adolescence and it approaches 18 to 21 years of age, there should be a bit of overlap between the adult world as well as the pediatric world. Eventually, as the patient assumes responsibility for their care, it's appropriate to consider transition all the way to an adult provider. I think key is that this transition or handoff doesn't occur overnight. There should be a significant amount of overlap as we help the patient with IBD who is a pediatric patient learn to manage their disease, learn to become facile with the resources available and the medical system, and then eventually transfer over to an adult provider. Many of you all have already tapped into the school resources that can be available for your child with inflammatory bowel disease. Can we do a show of hands for how many folks here have a 504 plan for their child? Can we do a show of hands? Okay, so we see 1, 2, 3, 4, 5. We see 6 people here that have a 504 plan in place. I'd highly encourage folks who don't have a 504 plan to consider asking your GI team for help with this. I want to go over this a little bit briefly. So Section 504 of the Federal Rehabilitation Act ensures that there are accommodations available for children with disabilities. And IBD is considered a chronic medical condition which fits under this, this heading of the Section 504. So the folks involved with a 504 plan and planning this include the school nurse, potentially the guidance counselor, a social worker, teachers, and the administrators at school. A letter is filed and it really defines what inflammatory bowel disease is, describes symptoms, and then it describes a variety of considerations that should be made for a patient with inflammatory bowel disease. I'll say many of you may have children who are functioning just fine at school, but when they have a flare, they may encounter some difficulties. And having this 504 plan in place is just a really nice sort of safety blanket if issues come up so that your child will be appropriately supported. So the request for a 504 plan is done in writing. And here in my IBD center, my nurse actually helps families draft this 504 plan. It includes appropriate medical documentation, and then of course it includes the appropriate parties involved at school as well too. a sample of some of the accommodations that the 504 plan will give your child are, first of all, a bathroom pass. So when they need to go to the bathroom, they should not be held up. They should be able to use it as needed. Pass to the nurse's office, training for the nurses for medication administration for your child. Stop the clock testing is a nice accommodation in my mind. So when a child has to get up to go to the bathroom because they're not feeling well, the clock should be stopped so they can come back and they can have the full, for example, 60 minutes for an exam. There should be accommodations made for school tutoring and support, and there should be time accommodated for example, time between classes so the child can go to the bathroom. As you all the children resources. You all can visit this www.ccfa.org. Then you will get to this wonderful resource. If you have a child who is getting ready to go away to college and you as a parent are dreading this and a little bit worried, we have to, one thing to think about is really talking to the college about the 504 plan and talking to the disability office about getting appropriate accommodations. Many colleges do not have private bathrooms or very easy for your child having either a private bathroom or a bathroom that is close by their dorm. They can have testing accommodations as well, so if they have to leave again to go to the bathroom, they should not be penalized for this whatsoever. If you want to look into sort of a little bit more detail about resources available for college-age children, the website is right there listed below at the bottom of this, and it's the same website that Kathleen mentioned as well. I want to touch a little bit about self-management. So as a GI provider, as a parent, I like to sort of provide the best care possible for my child, sort of oversee everything that's being done. I think it's important that we as providers as well as family members think about how can we best engage our children in the care as early as possible, sort of at a developmentally appropriate level. So just thinking about how to best involve a child in the care, I think there's some important screening to begin with. First of all, is there a support network of family members and friends that can be involved? Is there any role for a psychologist or a counselor? If a child is having a very difficult time adjusting to chronic illness, I'd highly recommend having a counselor or psychologist involved. Are there school accommodations that need to be in place, like the 504 plan things that we talked about? And does the adolescent or child need help with stress or anxiety reduction? So for self-management to be effective, to engage the child in helping to manage their disease, I think the first thing to consider is where is my child from a developmental standpoint? If you have a very young child, it doesn't make as much sense for them to be as intensively educated about the disease and management, but it will be important, for example, for the child to be thoughtful about knowing how to tell you as the parent about how they're feeling and how their symptoms are doing. For older children, understanding really what inflammatory bowel disease is important. And the CCFA has been wonderful about providing thoughtful, good resources for families. We'd like our children, as they become more developmentally able, to learn how to manage their disease well too, in terms of understanding what all their medications are, what the medications do, and what the side effects are as well too. Big picture-wise, we're gradually preparing our patients for independence and successful management of their disease once they are under the protective wings of their families. And we want the families and the children to know that they are absolutely central, and their treatment is not driven only by the doctors, the nurses, or the families, but they are central and critical for us to being thoughtfully able to manage their disease. Treatment adherence is a hot topic for chronic medical illnesses. For you all here, I imagine if you've been thoughtful and that you've been willing to take time out of your evening to join us tonight, I imagine that adherence is something that you've been intimately involved with your children. As they get older, it's more difficult to think about making sure that they are adherent to their appropriate medicinal or dietary regimens. We know that good adherence is associated with improved outcomes. For example, there's reduced inflammation in the GI tract. There's a decreased risk of progression of disease and needing surgery or developing complications. there's a clear-cut decreased risk of colorectal cancer with good control of inflammation. And we know that if you are good about maintaining adherence to your medications, you're less likely to have disease flare activity. So first of all, be informed and educated about what the medications are doing and sort of the consequences of not being adherent to the medications. One example is with Remicade therapy. If you are on Remicade and you miss doses for one reason or another, it may make it more likely that you lose efficacy to this medication. That sort of information about adherence to specific medications is important to consider. When I have children and families on inflammatory bowel disease therapy that becomes too unwieldy with too many medications, it's a way to streamline therapy. Being thoughtful about which medications are needed and which medications can potentially be weaned off can really help with adherence. Finally, really engaging the children in management. So if you have a child and they ask about, is it time for me to take my medications, or should I be taking those pills today? That can really be a wonderful way to engage the children and to help increase adherence as well too. We have some resources in the CCFA community about support for emotional and social issues around challenges with adherence as well too. Here at Seattle Children's, we have a wonderful social worker that's involved with families where there may be a concern about decreased adherence or sort of the children who are older not wanting to be adherent. So again, an important thing for us to be aware of and to intervene appropriately on. As we wrap up, I'd like to talk about some of the CCFA resources that are in place. If you have not yet had a chance to visit the CCFA website, this is an awesome resource. All of us GI doctors who treat inflammatory bowel disease, I'll say across the board, almost uniformly are part of the Crohn's and Colitis Foundation of America. As Kathleen mentioned earlier, Camp Oasis is an amazing opportunity for kids at Camp Oasis, both in Pennsylvania as well as here in Washington. And you see the kids really just blossom here. It's the first time that they've probably been around many kids with other inflammatory bowel diseases. And these kids have a great time. They can relate to each other. And this is the first time where they're not unusual for having to go to the bathroom. It's sort of the norm to have to go to the bathroom more frequently. I'd highly recommend looking into Camp Oasis for your child. The North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, or NASPGHAN for short, is the National Pediatric GI Association. We have some wonderful resources through NASPGHAN as well too. GIKids.org is a website specifically geared towards children and teens, and there are a lot of resources for understanding GI conditions, not just inflammatory bowel disease. The little cartoon I have on the bottom of this slide is a little YouTube clip about geared towards kids for understanding what an endoscopy or colonoscopy looks like. So if you go to gikids.org and your child's going to have an endoscopy, this is a really nice cartoon about explaining what an endoscopy is going to be like. There's also a college site, again, geared towards children who are transitioning away from home to live away at college. This is ibdu.org, and again, supported by NASPGHAN. I want to improve care now. This is a really wonderful resource that's come online over the past few years. This is a collaborative learning healthcare system. There are currently 87 pediatric institutions worldwide that are part of this collaborative. And really, this is a group of hospitals and physicians who are coming together with families and other caregivers to do good, high-quality research in inflammatory bowel disease. At your hospitals, if you've been approached about enrolling in the Improved Care Now, I'd highly recommend that you engage in this and think about it. It involves collection of data from the clinic visits and the collection of data being analyzed to see if we can think about how to be most thoughtful about improving care and outcomes for our children with inflammatory bowel disease. Before some questions about, and in conclusion, IBD is a chronic medical condition that uniquely impacts children and adolescents differently than adults. Therapy for inflammatory bowel disease should be involving medications, diet, and the consideration of possible surgery. Involving children in their IBD care is very important and can be done from an early age. And finally, we have resources available through the CCFA and NASPGHAN. And we'd really encourage you all to engage with your physician in asking about the different resources that are available for you and your child in particular in your region of the country. That have contributed to this presentation listed on this slide right here, and a special thank you to Kathleen as well too. She has been just a constant source of wanting to push forward IBD education and really advocating for families and caregivers of people focusing on children with inflammatory bowel disease. With that, I'd like to open things up for any questions right now. And Kathleen is here right now. So one of the questions I have here is, first, can you get a 504 plan at a private school? Absolutely, that should be the case. You should talk to your GI doctor and the school. I'd say the school administration. I think a 504 plan should be able to be obtained at a private institution. If it cannot be because of federal mandate, I think something very similar could be done. And again, this is supported by all public schools, and I think it should be supported in private schools as well. One question we have here is about athletics. The question is, what type of activity level and engagement in school athletics should I expect of my child when he is on Remicade and in remission? That's a great question. I like to give the example of people that have inflammatory bowel disease doing very well. I have an example of a patient of mine who was a high school senior. Actually, I saw him as a junior initially. He was started on therapy with Remicade, and he was a football player. And when he had his disease in remission, he felt so wonderful. He put on good quality weight, and he was running full speed ahead. There are professional athletes who have inflammatory bowel disease and on Remicade, and they are doing totally fine. So I would say if your child is on therapy and doing well, they should not be thought of as having any limitations to their academic activity or their athletic potential. So your child on Remicade with disease in remission should be encouraged to be active. I'll say one caveat. I would touch base with your physician about bone mineral density. Some children who have had a long history of inflammation may have bone mineral density that's a little bit lower. If that's the case, that'll need to be supported and followed over time with things like a DEXA scan. It's a special X-ray that looks at bone mineral density, and if that is found to be low, your doctor and dietitian may recommend some calcium and vitamin D therapy. A question about the link between oral contraceptive and Crohn's disease. That's a great question. So there have been large-scale epidemiological studies looking at potential medication exposures and the risk of developing inflammatory bowel disease or having disease flare. To the best of my knowledge, and I've done a literature review on this over a year and a half ago, there is not a clear-cut link between oral contraceptive pills or oral contraceptive medications and Crohn's disease, but there is a suggestion that there may be some flare activity. We know for sure that if you are a female who is menstruating, that during menstrual cycles there are major changes that occur to the hormones in your body, and sometimes with the shift in the hormones there can be abdominal pain and diarrhea. There's potentially the risk of some flare activity as well too. I would say that in general there's not a clear-cut link between oral contraceptive and Crohn's disease, but it's important to be thoughtful about what medications your child is on. I'll touch on one other thing. So there are certain medications for acne. They are the retinoids. These medications have been implicated as possibly associated with IBD flare. I've had a child who had severe facial acne, and the question was from the dermatologist, is it okay to this retinoic acid medication? If you do a clear, thorough review of the literature, there are clearly some reports of a suggestion of an increased risk of IBD activity, but there are other reports that say there's actually no increased risk with retinoic acid derivatives. So I'll say for acne medications, specifically the retinoids, the jury's out. There's no clear-cut association between exposure to these medications and inflammatory bowel disease, but we will learn more going forward. I see a question here about a 16-year-old, and I'm going to read this. My 16-year-old still doesn't have periods. She's an athlete, well-developed, 5'10", 134 pounds. Her growth scan shows she's 1 year behind on her joint development. When can I expect her to get her period? She's off meds, low-grade Crohn's, no complications. So I will say pubertal delay and sort of delay in menstruation is definitely something that we see with inflammatory bowel disease. So I would say there is a huge variance in terms of when girls enter menarche or begin to menstruate. There's a genetic component to this. So if mom has developed menstruation late, it may be the case that the child is going to develop menstruation a little bit later as well too. We know very well that if you have active ongoing inflammation in your body, and if you also don't have appropriate nutrient stores, you may have compromised menstruation. So for your daughter who's 16 years old and still hasn't had a period, I think it's very important to think about the status of the inflammation with her inflammatory bowel disease. She has ongoing inflammation. This could be compromising her ability to enter puberty and go through menstruation. I'm sorry, the sound quality is down a little bit. Okay. Sorry. I think we tried to fix the sound quality a little bit. Is it not good? So we're going to try one more time. Do we have any sound quality right? Are you hearing me okay? Okay, we're gonna switch over to a different microphone real quickly. One second. Okay, so here's plugging in the microphone right now. All right. Are we? Okay. Thank you all for hanging with us. Kathleen, maybe, can you all hear okay right now? Okay, thank you all for bearing with us for a little technical difficulties near the end. Real quickly, again, for your child who is 16 who has not yet developed menstruation, I think it's really important to be thoughtful about is there ongoing inflammatory activity. And I would also recommend that there be a good, close discussion with a dietitian about sort of appropriate nutrient stores on an appropriate nutritional status. Are there any more questions from anybody out there? Well, we greatly appreciate your guys' time this evening. We are so appreciative that there are families that are interested in learning more about inflammatory bowel disease and really pushing forward and getting the best quality care for their children. So we are honored as physicians and providers to be able to partner with you all. We see a couple last-minute questions. I'd like to go through these with folks as well too. So I'm going to read the question for the group. The question is, my daughter is 15 with Crohn's for 6 months on Remicade, Lialda, methotrexate, is a competitive dancer who trains 20 hours per week. She is struggling with weight gain and feels her metabolism is slowed by her meds. Is this possible? That's a great question. So we know that corticosteroids can clearly alter your body composition. So corticosteroids can cause increase in fat deposition, as well as it can cause retaining of fluid. Remicade has actually been demonstrated to be beneficial at helping you regain appropriate bone mineral density as well as appropriate muscle mass. So in general, Remicade should not be causing problems with abnormal weight gain. Methotrexate is a medication that generally is not associated with weight gain. it can be associated with some liver irritation and some blood count abnormalities. I'm not exactly certain if Remicade, Lialda, or methotrexate are the cause of your daughter's weight gain and altered metabolism. I would recommend that you all meet with your GI dietitian and discuss a little bit more about the types of foods that she's eating and if there might be some opportunities to tweak her nutritional intake. In general, Remicade, Lialda, methotrexate should not cause abnormal increased weight gain, though. There's a question I'm going to read. It's our 11-year-old daughter has been on Remicade for 6 months. Her calprotectin is still very high, greater than 1,000. When do we try something else? So this is a question that's going to be important to discuss further with your GI doctor. I'll give you a little bit of general principles, though. Really, when you start a new medication, it's very important to see how your child responds to these medications. It's important to look at how the symptoms either improve or do not improve. It's also very important to look at objective markers of inflammation. Blood counts and blood markers of inflammation are important, so that would be CRP and ESR. And for everybody on this webinar, fecal calprotectin is a measure of intestinal inflammation that you can measure in the stool. So a normal calprotectin level, a stone cold normal level, is less than 50. If a calprotectin level is greater than 1,000, it's suggestive that there's ongoing inflammatory burden. And I'll give you my general practice. My practice is if there is not sort of at least a trajectory towards improvement in inflammation, I'm discussing altering the therapeutic approach with my patients. I'd say I give therapy in general about 2 to 3 months. If you're at 6 months and you're continuing to have elevated fecal calprotectins, they're not trending downward, I would recommend touching base and speaking a little bit further with your GI doctor about what the right approach to therapy is. In general, Remicade should be effective within, you should start seeing benefit within about the first 2 to 3 months. Okay. Are there any other questions from the group out here? Okay. Well, we'd like to thank you again. It's been our privilege to hang out with you all this evening and talk a little bit of inflammatory bowel disease. We hope that you have learned something from our presentation or at least found some good resources. So I'd like to say thank you all so much and have a good evening from Kathleen and myself.
Thank you, Dr. Lee.
Thank you. Bye.